I'm going to try some Polish. Cześć. You know, I actually studied Russian early in my college years, and for some reason I thought Russian was a little bit close to Polish, but no way. So maybe a teeny bit of words. Maybe your goodbye is a teeny bit like do svidania, but I love being here in Poland. I love Krakow, and Torun is an amazing place. So thank you so much for having me. You know, I've been listening to the past few conversations, and I've been in this sector for a very long time, the long-term care sector. I was 26 when I started working in this sector, and I'm now 73, so my entire career has been working in this sector. And the one thing that I think we miss in long-term care, and I preach this to every choir that I can in the United States and elsewhere, is that it's really the people, stupid. It is the staff who do the work that make the difference in what we do every day and whether we are producing good quality of care and, as important, good quality of life. And I think if there's anything that we can leave messages with to our managers and our CEOs and anybody else that's paying attention to this, is that person-centered care and person-centeredness is a dyad. It's not just the person that we are serving. We are employers of millions of people across the world who work in the sector. And they're going to be critical for the foreseeable future. As people have told me that there are robots all over Japan right now delivering services. I can tell you I do a lot of work in Japan, and there's no robots that are delivering most of the long-term care in nursing homes and in home care in the oldest country in the world. So we are very far away from having AI completely replace the human capital that is needed for us. And so if we keep that message in the front of us, I think it's going to be very critical. And in particular, I mean, I want to talk about a really important part of this staff. And that is the staff that I think has been missing a little bit so far in our conversation. And that is the frontline. The frontline direct care professionals who, at least in the United States, do 60 to 80% of all the hands-on services in the long-term care sector. And just so that you know what I'm talking about when I talk about the long-term care sector, these are all of the different settings in the United States, and I know that we can't compare apples to apples across the world, but you have something similar here in Poland in some way, shape, and form that ranges from post-acute care and home health care to residential types of services in social care and in other types of residential environments. I don't know the extent to which you have a home care system here in Poland, but certainly in the US and across many of the other countries in Europe, Australia, New Zealand, and Asia, home care is replacing residential care in many places because people want to remain in their own communities and want services that are not in residential environments. So there's tremendous focus on home care development. And then we also have the supportive services that go along with that. And this sector is very diverse, and the settings are very diverse. And within that, we basically have primarily a direct care professional workforce that is doing most of the work. What's interesting about long-term care, very, very different from the hospital sector, for example, or even primary care, is that, I don't know why this is moving, but let me try, is that we are talking about, in long-term care, the medical, social, and physical environment intersection. There is no other place in any industry where people actually are doing services where people live. If you're working in a hotel, you're delivering a service, you leave that hotel and you go home. You're not working in somebody's home, but if you are working in a nursing home, other residential environment, or home care, you work where people live. This is an incredibly difficult and unique environment, and I think it's very important for us to figure out how we're going to develop this staff, the long-term care staff, separate from medical care staff and other staff in the larger healthcare sector. Long-term care is really its own unique set of settings and competencies. We need to be a lot clearer about what we're talking about when we talk about the long-term care space. The frontline staff that I'm going to be talking more and more today about is really these, in the United States, we call them nursing assistants, home care aides, personal care aides, dietary aides. They're really the frontline folks. They're not nurses, they're not social workers, they're not physicians, they're not physiatrists, they're not therapists. They're the front line that do most of the work. And if I leave you with one message, it is that these are highly competent, very skilled people who, for the most part, in the Western industrialized world, have been treated as low-wage workers. We have to begin to change the nomenclature of these professions, and we have to professionalize this staff if we're actually going to get to quality outcomes, both on the quality of care and quality of life side. In the United States, at least, most of these these professionals are females, they are low income, and they are people of color. A large proportion of those folks are immigrants. Now, I don't know whether that is true here in Poland, but I can tell you that I look at this audience and I don't see one person of color in the entire audience. So I don't know whether this reflects Poland's long-term care system or whether we're looking at the people who actually are the managers and the higher level folks, and whether you also have much more diversity in your front line. But I do know that throughout most of Europe, we have a very, very diverse frontline staff caring for folks across settings. And this makes it extremely difficult because these folks are very vulnerable themselves. We're going to see an emerging care gap over the next few years because in the United States, as well as in Asia and in Europe, we're actually starting to see less people who are going to be available to work in our sector to care for older adults. In addition, we are seeing some fraying of the family caregiving system. We are certainly seeing that in the US. We're seeing that in other countries, partly because there's a lot more people who are not having children. They're having fewer children. There's a lot more divorce, which actually ends up disrupting family caregiving situations. So there's going to be a lot more demand for this frontline staff than we've seen right now. In the US, we're just at about 19% over the age of 65. Japan is already at 30% over the age of 65. I'm not exactly sure where Poland is in that environment. The oldest country here, I think, in Europe is, if I'm not wrong, I think it's Italy. I could be wrong, but Italy is pretty much up there as well. But we are an aging world. So this frontline staff is going to be critical for us. We're seeing this huge shift from institutional to home and community-based services around at least the Western industrialized world. More ethnically and racially diverse older adults. We certainly see that in the US and in Canada. We're going from about 20% to 33% non-white older adults in the United States over the next 20 years, and we need a lot more culturally competent training for our workforce in general to address a lot more diversity, both in the staff that we have as well as the people that we care for. The other thing is that we're seeing more highly educated older adults in most of the Western industrialized world, which means that these older adults are going to put a lot more pressure and demands on our staff across the board, and we're going to need to be ready for that. I'm part of the first baby boom generation in the United States, and I can tell you I'm very, very different from my grandmother, who was a Depression baby, an immigrant, and didn't place a whole lot of demands on a long-term care system when she was in the nursing home. That I don't think is going to be me. I'm going to go past this one and talk about why this is so important. Not only the growth of the older adult population, But as we develop new models of service delivery across the world, and we look more at home and community-based services, and we also look more at how we're going to have more person-centered care, we need to actually pay attention to this frontline staff, because they are the ones who are delivering the person-centeredness. They're actually the folks who know the residents and the clients, much more than most of the more professional nurses, and certainly physicians who are often not involved at all in the long-term care sector, or at least minimally involved in the long-term care sector. So this frontline is critical to that relationship building. In addition, these are the folks where jobs are growing. In the United States, home care aides are the fastest growing jobs. So they are driving economic growth in most communities. And I think that we need to be talking about our sector and the growth of these jobs as part of economic solutions to our communities. That's only going to be true if we actually make these viable jobs that people want to have. And in the United States, at least post-COVID, we are having significant challenges in terms of recruiting and retaining frontline staff. This is causing many of our organizations, both on the nursing home side and even on the home care side, to turn away residents and clients and to actually close their doors. So this frontline staff is essential for the future, and as I said before, it's essential for quality outcomes. Just to show you in the US where our direct care employment is, and I don't know how this holds up in Poland, but over 50% of all of our workforce is actually in the home care sector. Only about 10% work in nursing homes in the United States. Nursing homes are sort of our equivalent to your social care homes. And then we have residential care in addition to nursing homes. We call it assisted living in the United States. 14% of this frontline are working in there, and then there's other settings as well. But over half are in the home care sector. So I've heard a lot today about nursing homes, but I think that in Poland, as in other parts of the world, we need to be paying attention to how we're going to develop this staff in home care as well. We're going to see more and more of this. And home care is much more difficult than in a residential environment because you have very little control and very little oversight around folks who are going into the home. And that means we have to figure out how do we create high-quality jobs, accountability, and support for oftentimes an aide who is the only person in the home, in addition to perhaps a family member. It's a very, very difficult job. I have shadowed many home care workers, and it's extremely difficult occupation. This is a pretty difficult slide to read. I just here am showing you that there is a really high preponderance of women. Not surprising, and I can see that I think we've got a lot of women in the audience here today, but we also have seen more men than I often see in some of my audiences, which I think is fantastic. But a lot of women, you can see for this second green color is immigrants. You can see it's really high. It's over 30% of our home care aides in the United States are immigrants. In residential care, it's about a little over 1/5. And nursing home, it's a little over 1/5 as well, almost actually a quarter. Another piece to understand with this bar chart is the fact that a lot of these folks have children under the age of 18. So they are struggling with their own family situations. And these are often, at least in the US, these are single mothers or single grandmothers who are actually doing this care and then also caring for kids. And many of them in the US, that's the last blue, that peacock blue, are living below 200% of poverty. So this is a very critical situation. As Dan said, I just came from Scotland, and I know that at least in most of the Western European countries, they're facing exactly the same thing. What we are doing in long-term care is we are hiring and supporting low-wage workers to do all of this work in our sector. They are poor themselves. In the United States, about 40% of this workforce is living on public benefits. So to my mind, this is a travesty that in the 21st century we continue to have an LTSS system that is basically built on the backs of two populations. Number one, the family caregiver, who tends to be a woman, and number two, the frontline professional, who tends to be a woman as well. So somehow we got to do something about this. If we didn't have this workforce, and as I said to you right now in the US, we're seeing a challenge, significant shortages post-COVID. If we did not have this workforce, we wouldn't have the sector. And that is really critical for us to recognize. We are facing serious recruitment challenges. I don't know about Poland, but in the United States, after COVID, the wages have been raised somewhat for frontline staff, but they've also been raised for Walmart, for Carrefour, for Amazon, for every other place that these folks can work and make more money. And so the competition is fierce for this workforce. And we are having a harder time than ever in recruiting. And unless we change the value of this job and differentiate ourselves in the long-term care sector as a place where people want to work, we're going to continue to see this just as we age even more. In addition to that, and I would argue more importantly than recruitment, is our challenges around retention. You heard about burnout in the last presentation. Our retention rates in the United States vary tremendously, but it is not unusual for us to have between 60 and 75% turnover, particularly in the first 3 months of a hire. And so the goal for us as providers, as managers, and as folks who work in the product sector is to help our providers and the employers to actually develop healthy workplaces where we can train and retain high-quality staff. That needs to be the goal of our organizations. We don't want to just hire competent, we don't want to hire warm bodies. And we have seen this in the US post-COVID because it's such a challenge to get anybody in the door. But every time you hire somebody that is not competent and that leaves within 3 months, in the US we're paying at least $4,000 to $8,000 per person. And with huge turnover rates, you can very quickly see the cost of that to an employer and to society in general. So the goal should be to focus on recruiting high-quality people who are trained well, pay them well, and retain them so that you don't have all this churning and you can actually have a stable workforce and produce good quality outcomes. And that is a pretty simple message. And in the 23 years of being at Leading Age, and in my 25 years of working in policy and research for the federal government in Washington, D.C., I have yet to see much change in the sector. So I know how difficult it is. It's very simple to talk about this, but on the other hand, we don't have much choice because the aging of our society is going to demand this. Japan is already below dependency ratios. They don't have enough people to even support their older population, which still is growing, and particularly among the old. Let's not make the same mistakes and really try to figure out how we develop a formal workforce to support the aging of our society. So the reasons are really very clear at the societal level, and I think this is true, and Dan talked about this earlier today. We are an undervalued sector. Across the board, we are undervalued. Ageism is prevalent, and it's a lack of attention and investment on the part of governments and on the part of society in general. Nobody wants to pay for somebody to come and help you, even if you're wealthy. Nobody wants to get old, and nobody ever wants to use the services that we provide because it's seen as something that's negative, and certainly nobody wants to die. And as everybody has said, we're not getting out of here alive. Right now, there isn't a soul here that's going to get out of here alive. So we have to start talking about this seriously. The jobs are often seen as very easy and a job that's done by default. If you're a nurse, you come to long-term care after you've been in the ICU, when you want to rest you go to long-term care. And as you heard in the burnout session, it's not a very restful environment, but I will also tell you, having been in this for a very long time, it's an incredibly exciting environment and very much needed. So we have to actually turn the view around of what these jobs are really like. And finally, on the frontline side, most of these jobs are often called unskilled. At Leading Age, we have 18 pages of competencies for frontline staff. Now you tell me, with 18 pages of competencies, how can those folks be unskilled? When you're caring for people with dementia, when you're caring for people with the kind of comorbidities, and you are trying to avoid decubitus ulcers like we just saw, and you know who's avoiding them? It's the people who are actually taking folks to the toilet, or taking them, making them mobile, or if they are homebound or bedbound, turning them every 2 hours. That's the staff that's making the difference in this quality. They need to be trained and they need to be supported. The reasons for challenge at our policy level is we have terrible public reimbursement. So our reimbursement is so low that it's really difficult even for our employers to pay a living wage to our frontline professionals. Our average was about $14 an hour in 2021 for a frontline staff person. Now, I don't know what the equivalent is here in zlotys, but we pay very low wages on average in the US. We need to, we actually need to also look at uneven regulation that focuses on numbers and not on the quality of training that the staff gets, and the lack of investment in workforce development. I look at what Germany is doing, and Germany is a wonderful example of an investment that they have made in workforce development around this sector. In the United States, we are way far behind in terms of looking at opportunities for professionalizing this staff and providing a career advancement. And then for us, uncertainties around immigration policy. Whether we like immigrants or not, 25 to 30% of all of our staff are from other countries, and that is going to continue. They are a critical pipeline for the United States and for other countries around the world. We need to figure out what's good, quality, ethical immigration that allows people to come in, does not exploit them, provides good training and good human rights protections. And that's going to be critical, I think, for all of us that are relying on any immigrant or refugee populations as part of this workforce. At the workplace level, I would put the #1 fault on nurses. And I love nurses. I'm not one, but I work with a lot of them. But nurses, at least in the United States, control most of our nursing homes and home care organizations. They are the frontline managers. They are not, on average, good supervisors. And our frontline staff leave because of their supervisors. So as all of you are thinking about training your nurses for your clinical jobs in long-term care, you also need to be thinking about training your nurses in supervisory skills. They are critical for actually helping to recruit and retain a frontline staff. We also need much better onboarding and peer mentoring for our frontline staff, as well as career options. Some aides want to become nurses. Others may want to go into social work or human resources. Many of our aides are fantastic at behavior management. We ought to be thinking about them for mental health professions as well. Medication aides, just developing specialties, and also thinking about how we actually make our workplace technologically competitive. Because if we're going to hire millennials in our organizations, we have to be able to allow for folks to actually use the latest technology. We have examples in our organizations of people who tell their frontline aides, you leave your phone at the door when you come into this organization. Well, telling somebody, a millennial, to leave their phone is like cutting the millennial's arm off. And so we have to actually allow people to use their phones and their other technologies to actually communicate, to share data on what they're seeing in changes of condition. Let's turn it into something positive. And that really is part of the solution. So in the US, at least, we've got to do something about reimbursement policy. And I don't know whether that's true here in Poland, but for us, because we are so dependent on public payers, we need to look at reimbursement policy in a much more serious way. We have to create competency-based training. You heard about competencies in the last presentation. This is critical, and it has to be competencies across all settings, not just social care homes, but also in home care. We have to support investments in these jobs in worker shortage areas. In the US, for example, we have serious problems in our rural communities, and I would imagine in Poland you have serious challenges in your rural communities as well. How do we get workers into those shortage areas, and how do we support them? How do we use immigration policy to better target the development of these frontline occupations, and then incorporating our core competencies into new models of care as we move into much more person-centered delivery, and as I said, also home and community-based services. And finally, I think we need to explore better, and I think the last conversation, as well as Dr. Grabowski, both talked about delegation opportunities. And I know we have a lot of nurses in the room, or at least some nurses in the room, but the potential for delegation in terms of actually allowing frontline to do more so that nurses are freed up to do the higher level clinical work that is required with much more high acuity residents and clients. We need to be thoughtful about how we delegate and then how we support, train, and supervise that delegation. At the educational level, at least in the United States, we don't have a challenge as much on our nursing side. We have a challenge with the faculty. We don't have enough faculty to train our nurses and our frontline. And we don't have enough curricula that focuses specifically on, long-term care. You can't take someone from a hospital and just plant them in a long-term care setting. It's a totally different environment. And yet that's what we've done a lot in the United States, and I think in some other countries. As I said before, this is its own sector, and we need to develop it that way. Have more career ladders. Reframe programs so that older workers or displaced workers can be attracted to our sector and work. We have a lot of people in the US over the age of 65 who need to continue to work. How do we create jobs that are ergonomically sound? They can't lift, obviously, but with technology and with job sharing and job redesign, we might be able to employ a lot more older workers in this sector, which I think would be fantastic for everybody concerned. And then at the workplace, I believe every employer should become an employer of choice. Everybody should want to work at your organization. How do you develop career lattices and career ladders within your own organization? How do you support really good quality supervision, which I think is really pretty critical? And then think about the use of technology to support and complement human capital. In our organizations, many of our people become very enamored with technology. They want to buy the fanciest new gizmo. And the truth is, what we need is technology that supports humans. And is this a good investment? Is it something that's going to be around for a while, or is it going to be obsolete within 2 days after you purchase it? And have your front line involved in the decision-making process. I heard some discussions around teamwork. Oftentimes, that team does not include the frontline professional who, as I said before, does 60 to 80% of all the care. So make sure that this frontline person or set of people are involved in your decision-making and in your teamwork. Before I close, I just wanted to show you something that we did in the United States. We actually modeled what would happen if we gave every single aide in the United States a living wage. And the living wage cannot be set at a federal level in the US. We've got millions of people in the US, and we've got 51 states, and you could never set it at a federal level. It has to be set at a market level. So we basically modeled what would happen if we gave every direct care worker a living wage in their own market area. And as you can see, 3/4 of those direct care staff would receive higher wages than today, about a 15% wage gain. We also would have much more money in the hands of frontline workers, which means they would be buying goods and services in their community, which means they would be generating tax revenue for their communities, which means they are an economic asset as opposed to a deficit in their communities. We see fewer staff shortages, which added up in the US to more than 330,000 direct care worker jobs, almost a 10% employment boost, with effects on reducing turnover as well. So you can see that there's ripple effects to actually treating these jobs professionally and investing in them. And we need to be selling this to our mayors, to our chambers of commerce, to everybody in our communities, that these are viable jobs if we can invest in them, because they are going to help us support successful aging in community. Obviously, it enhances the direct care worker financial well-being, which at the end of the day is an extremely important goal for all of us, because these are very vulnerable people. So why am I hopeful? We have a lot of increased attention at the global level. The World Health Organization has absolutely seen this, and it's on their radar screen. The Global Aging Network, which is an organization that my organization is part of, and where we had our last meeting in Scotland, it is #1 on their focus, as is the UN is paying a lot more attention to this workforce. In the United States, we have seen, because of COVID, and I don't know whether this is true or not in Poland, but COVID actually shined a light on this workforce as essential workers. When all of those people died in nursing homes or in home care, the folks who lived and thrived were because of that front line, who put their lives at great risk to support these people. And so this has put a lot more attention on this front line. Our Department of Labor in the United States is finally emphasizing new apprenticeship programs for these workers, taking a lot from the German model of apprenticeship, which, if you don't know that model here in Poland, you should take a look at it. It's absolutely fantastic. And we are also paying attention to systemic racism, inequity, and disparities in the United States, of which many of our frontline workers are victims of. And so that is raising the flag as well in terms of attention. And with that, I'm going to conclude and just come back to the very beginning of my talk, which was, it's the people, stupid. Let's all come together to make sure that we invest in the staff, and particularly the frontline staff, who are going to make the difference in the lives of the people that we care for every day. And thank you so much for having me here in Poland and for giving me this wonderful treat to spend my time here in this terrific community. And I'm certainly happy to answer any questions, but I don't think we've had any so far, so.
Are there any questions from the audience? Anyone have a question? Oh, good, we have a question.
Dzień dobry, jestem pielęgniarką. Mam takie pytanie, bo powiedziała Pani... Aha, tłumaczenie.
I don't have my thing on. Anybody translate it for me?
Już chwilkę. Tak, dziękuję. Mam takie pytanie, bo mówiła Pani o tym, że ludzie są najważniejsi. Ja tak rzeczywiście też uważam, myślę, że większość z nas też. I powiedziała Pani taką ciekawą rzecz na temat tego, że ten pacjent się zmienia, że on jest inny. I ja też to widzę u mnie w pracy, pewnie wielu z nas też. Ale zmieniają się też te zespoły i mamy takie zderzenie pokoleniowe, widzimy to bardzo mocno, gdzie jakby zdarzają się pokolenia różne, starszych pielęgniarek, opiekunów z młodszymi. Każdy z nich oczywiście wnosi jakąś wartość. I chciałam zapytać, rzeczywiście jednak tutaj często spotykamy wiele problemów na linii komunikacji. I chciałam zapytać, czy są jakieś takie dobre praktyki, którymi się mogłaby Pani z nami podzielić właśnie w kontekście tej komunikacji? Albo co możemy zrobić, żebyśmy byli bardziej zgrani i pokoleniowo się dogadywali?
You know, that's such a fantastic, it's such a fantastic question because it affirms a study that we did recently in the United States. We were actually looking at what actually predicted staff turning over during COVID. And we had some really great data. We had thousands of data points to look at. And the most important factor that determined it was good communication actually kept people on the job. And I think that you hit the nail on the head in terms of focusing on communication. I don't think I have any one good best practice other than to say that teams need to really be developed as teams, which is to say that self-managed work teams are not hierarchical. They all have tasks and competencies to do within the team. And the information across staff and between staff needs to be shared constantly. And I think understanding the modes of communication between older workers, older staff, and younger millennial staff, as one example, is really critical to understand the way that people talk to each other. In our country, because we have so much diversity, that's also a real significant challenge. One example is a Caucasian nurse who was working in Boston in a nursing home who had mostly a Vietnamese workforce. And the Vietnamese staff would never look her in the eye when she was talking to them. And so she interpreted that as them being disrespectful and created horrific problems. When she found out through some consultant training that actually many Asian cultures look down when they are talking to a superior, she actually understood that it was a very different situation. It changed the entire dynamic of how they talk to each other. I mean, the nuances of communication, body language, how close people get to each other, the kinds of words that they use. Going back to the technology piece, one of the things that we struggled with in our membership at Leading Age was this challenge of millennial staff, you know, being with their phones all the time and thinking, older nurses and older staff folks thinking that they were just screwing around and not doing their work. And instead of looking at it that way, they turned those technologies into tools for actually helping them to document better, to share information and to communicate within teams and across staff and across shifts, because that's the other thing that we see as a best practice, which is shift handoffs are so critical. If your staff from shift to shift are not accountable for each other and are not sharing information, there is tremendous amount of breakdown. So I think, you know, you could go to the Leading Age website. We have tools around communication. A lot of it is common sense, but the application of good communication is very difficult because it's a continuous journey. So thank you so much for raising that, because I do think it's part of the solution to our problems. Thank you very much.